So good morning. It's very fitting that this session today on models of survivorship care delivery follows yesterday's extensive discussion on the domains of concern and the evidence-based interventions that are available to both patients and families. Because what we're really going to be talking about is the architecture of healthcare delivery and how do we actually get these services to the individuals who need them. And first, before we hear from our speakers, by way of background, what I'd like to do is highlight the fact that the authors of the original Institute of Medicine report back in 2006 had a very extensive chapter on healthcare delivery. And included in it were a description of the services available at that time for cancer survivors and their families. And most of them were single services, such as psychosocial support groups, but they also listed where they did exist models of care, and they were primarily the multidisciplinary model of care, long used by our pediatric oncology colleagues for decades prior to that report. And they also, again, described the beginning models of care for patients with adult onset cancers that were just beginning in some cancer centers around the United States. But we've come a long way, and I think we've actually moved the needle in this regard with models, and have developed a taxonomy for models of care that we really need to begin to not only implement, but implement while we evaluate. And so what we would like to do is begin to discuss some of those, because we really have refined our approach, and rather than a one-size-fits-all, looking at who needs what and for how long and with what provider. So where we are really now is really thinking about the structure of the model and the provider and looking at what it's dependent upon. And you'll hear from our speakers about how they've actually applied this. And using a risk-based approach to care, and a number of people in this room have written quite extensively about it, and looking also within our healthcare systems, what are the additive additional types of services that we need to really include to have comprehensive care for cancer survivors, and also looking at the timing of those services, whether it's a one-time consultative visits or it's ongoing care. And we heard yesterday about the need for continuing care from the time of diagnosis. And so if we really take this paradigm of a risk-based approach to care, I like to highlight one of the really ongoing models is the multidisciplinary model, again, used in pediatrics for those individuals at high risk for late effects or recurrence that need intensive approach to their follow-up care. And it can be also used, for instance, for the patients with allo transplants, those young adults Kevin Effinger mentioned in his talk yesterday at high risk of problems, and this is a model that's very well utilized in that for this patient group. But most patients really have moderate risk for problems going forward, and really can fit into the models of care that are described here on this slide, and the disease-specific ones often provided by nurse practitioners and physician assistants, integrated care, which is ongoing care embedded in the oncology team, and the consultative model, which is often employed for the delivery of the treatment summary and care plan. And now we have also a low-risk group where we really ought to be looking at, and other countries already do this, at shared care between the generalist and the specialist in oncology, and an early handoff for the follow-up care of the survivors and their families to the generalist and the generalist practice. This is complicated to do, as was discussed yesterday in the United States, because of the rarity and the shortage of primary care providers. But we can really look to our colleagues in other countries to really learn and begin to apply. So what's the state of the science? We have more work to do. The results to date are mixed about the types of providers. There's been research done looking at the comparison of PCPs with oncologists and nurse practitioners and other advanced care providers. And we really do need to begin to look at these models within the healthcare systems in which they can be developed and employed. And more research is needed, but again, as I said, to do it while we're implementing them. Deb Mayer mentioned some of this yesterday, and so this is an additive contribution to the discussion about where are we in terms of our research. And so what I'd like to do is just mention 3 additional models that aren't quite so tried and true to date, but are important ones to begin to think about. We borrow, in using them in oncology, from a chronic care model, and I think that they were mentioned in passing yesterday and are worth highlighting. The first one is a self-management model, where there's certainly significant evidence, and it really does promote skills in decision-making, taking action, in particular with communication with various providers, and can be used for psychosocial support, managing symptoms, and encouraging promoting healthy behaviors. In addition, group visits. This may be a very nice way of really doing symptom management, thinking about psychosocial support, and done in a way that really for systems with limited resources that can actually make a difference in the lives of patients and their families. And we highlighted yesterday the important needs of families themselves independently, and this might be a model that could be utilized for families in particular, separate from the patients that we focus on. Virtual follow-up care. I think we hear a lot about telemedicine, and this is something that could be employed for survivorship and a model of care. Very useful for counseling and also for symptom management. But I would say that in addition to the high-tech opportunities that are available, telephone counseling, still something that can be done very inexpensively, and again, thinking about the health system in which you live and what you might do to make a difference and make a change. And so as we move forward in thinking about various models of care, groups and individuals have really been calling for a research agenda and how we might do this. And I think it's worth thinking about how we might, in place, begin to implement, evaluate, revise, and improve over time. And so looking at some of our needs, going to the future, having looked at what we have now, we really need to develop a common understanding what constitutes usual care for this cancer survivor and compare it with survivorship models. And what have we known from the IOM report is the ideal set of services. Develop a common taxonomy for the various models, a set of outcomes that are important for each group. We've spent time on process measures, but really haven't done very much in the area of outcome measures to date. And look at the content delivery and utility of care plans. A lot of discussion nationally on an ongoing basis, but really do they do the job that we think that they should be doing and that we need to have done? Assess cost of formal survivorship care and services in order to determine value. We heard a lot yesterday about value in cancer care. Importantly, to identify the unique needs of survivors in underserved populations. And so yesterday there were a number of comments made that call out those individuals working to develop and evaluate models of care. And so I'd just like to highlight a few of them for you because they're very applicable to this session this morning. Implement what we know. Resist the impulse to provide all care to all survivors. We built it, but they didn't come. We need to think about using team-based care. We have to practice differently. We need to rethink how we deliver care. We can do it. And most importantly, I think, is what Mary Scroggins said at the end of the day yesterday is, just do it. So I'd like to rename our session the Just Do It session. And so along those lines, I'd introduce our first speaker, Keith Argenbright, who's the director of the Moncrief Cancer Institute and a professor and chief of community health and science at Texas Southwestern. And so what he'll be able to talk to you about is really the idea of how you don't build it and wait for them to come. You build it and you bring it to them. So Keith.